Should we start?
Sure.
And then we will see as people join in, they will join in. They're joining on YouTube. They will join in here as well, slowly.
Sure. Do we see the number of participants?
Yeah. Should we start?
Yeah, we're ready. Yeah.
Well, good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 18I, which is hematology and hematolymphoid. And we are streaming live from Minneapolis via Kolkata. A very interesting topic, Hematolymphoid Potpourri, a case-based webinar from classic to esoteric and a whole lot in between. And to talk on that, we have somebody who's an international expert on hematolymphoid areas, which is Dr. Ajay Rawal. He's an MD, staff pathologist, Health Partners and Methodist Hospital, Minneapolis, USA. He's got multiple publications in national and international journals. And he was a staff surgical pathologist and hematopathologist with special interest in neoplastic hematopathology and non-neoplastic lung pathology from 2012 to till date. He's also the staff surgical pathologist at the Minneapolis Veterans Affairs Medical Center from 2006 to 2012. Trained at PGI Chandigarh between 1995 to 2000, including 2 years of senior residency. Did his residency in the US at the UT Southwestern Medical Center in Dallas and at Evanston Northwestern in Chicago. Hematopathology Fellowship at the University of Michigan. Before I ask Dr. Rawal to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Rawal, sir, please share your screen and let us start.
Let's see here. Okay, can everybody see this screen?
Not yet.
Okay, hang on.
We can see your screen on a different screen.
Let's just see what I need to do. For me, it says your screen is still visible to others.
Yeah, it is, but only a part of it. I mean,
okay, let me.
I think you need to go back.
Wait, why don't I go back and redo this?
Yeah, I think you stop sharing and then you start resharing. Yeah, just your entire screen, then press in the center and share. Right.
How's this?
That's perfect. Please start.
Perfect. Thank you. Yeah. Thank you, Dr. Nadeem, and thanks to the PGI pathology community for this opportunity. As Dr. Nadeem mentioned, I worked at Methodist Hospital, and today what I plan to do is just kind of go over some interesting cases that range from absolutely classic forms to more unusual forms and a whole lot of bit in between that come across, on a day-to-day basis. So in the middle of all your regular routine stuff, there are these cases that are important and give you a teaching lesson every time. So let's just get going, and I'll start off with case one. Case one is a 53-year-old male who presented with elevated PSA, and as a means to evaluate the prostate, they did an MRI, and that is what revealed some inguinal lymphadenopathy, also some iliac lymph node enlargement. No other lymph nodes were enlarged, and an excisional lymph node biopsy was performed. So here we have the lymph node section, and as you can see, we see a lot of follicles here. The cortex here is expanded by this, what appears to be follicular hyperplasia. There's some attenuation of the mantle zones here, but easily, even at this power, one can make out that there are a lot of these tangible body macrophages imparting a starry sty appearance that you see typically with floridly reactive follicles. Also of note, there's a pretty thickened capsule here we see in this lymph node. At higher power, here 2 germinal centers here. They look very reactive. Obviously, physiologically, germinal centers are highly proliferative, and there's a lot of cell proliferation and cell death going on, and we see evidence of that with mitotic activity and tangible body macrophages eating up the lymphocytes that are not the best fit. for the antigenic stimulus. So all this would indicate that we are dealing with a very reactive lymph node and not a lymphoma. Right. Here in the capsule, kind of again see part of the thickened capsule here. Some of these cells here you'd recognize as plasma cells with this eccentric placement of the nucleus, paranuclear half, some cartwheel type nuclear condensation. So plasma cells kind of in the second capsule. All right. At this point, maybe from the audience, are there any thoughts? What do you think might be happening, or any other workup that we might do?
Yeah, we just wait and we'll just see for any response. There are quite a few people there.
So the reactive part looks fairly non-specific, right? I mean, we have reactive follicular hyperplasia. You see that in almost every benign lymph node that we get on our desks, So not particularly specific, right? Any other clue in the histology that might spur you to do something else? All right. Here's a stain. This is the immunostain we did. Obviously, something is marking, right? Here is a little higher power. And an even higher power. Any ideas what we are looking at? These elongate structures that are being highlighted by the immunostain. Obviously, it is teeming. The lymph node is teeming with these structures. All right. Well, the thickened capsule here was a big clue for us to test for this immunostain, and we did apply this antibody for Treponema pallidum, and this is syphilitic lymphadenitis. As you can see, this is not subtle. It is completely filled here with these. There's a lot of organism load at this point. So what we are dealing with is syphilitic lymphadenitis. The biggest clue here, obviously, is the thickened capsule and the appropriate clinical lymphadenopathy in a middle-aged man, which is otherwise unexplained. So this follow-up, when he underwent, examination, there were 2 erythematospinal lesions that were found, but the determination was not known. He did undergo serology for syphilis. His RPR was positive at the titer of 512. So there was no signs of neurosyphilis. He was treated with penicillin. His lymphadenopathy resolved on follow-up, and the titers decreased. He did develop some unexplained tinnitus 3 months later, which was treated with 2 weeks of IV penicillin for presumed otosyphilis, and has been doing well at his last follow-up. So quickly, just want to reiterate that thickened lymph node capsule is an important clue in the appropriate clinical context, and obliterative arthritis with plasma cells, while that is a key feature that is, can be a big clue towards syphilis, may not always be very conspicuous, but the marked thickening of the capsule in inguinal lymph node should be an impetus to do some additional testing. And if you don't have the immunostain for Treponema pallidum, certainly a serology could be done, and that could point towards the right diagnosis. All right, that was case 1, and we'll go ahead to the next case. Maybe we can just do any questions at the end of the talk, or if anybody has any question right now, I'll be happy to address now as well.
What would be the other differential diagnosis for this thickened capsule in the inguinal lymph node?
Right. It's very non-specific, I must say. It's just the degree of thickening, You also see thickened capsule in Castleman's disease, not infrequently. It can just be, inguinal lymph nodes obviously are the ones that show most reaction because of a lot of injuries and on the feet and so on. So they are the ones that tend to have most thickening. But it's just the sheer degree of capsular thickening in this that was very, very conspicuous. as far as the lymph node itself, it would just show reactive follicular hyperplasia, not very specific. So I think part of it is just index of suspicion. In this particular case, because it was extraordinarily thickened and there were readily identifiable plasma cells in the capsule, even though there was not the characteristic obliterative endarteritis, that was the reason for us to go ahead and just do a stain. And here's the next case here, a 79-year-old male who has a long-standing history of CLL, also has episodic autoimmune hemolytic anemia. So he's been previously treated with chlorambucil and this CD20 inhibitor, obinutuzumab. But now on follow-up, his CT showed increasing lymphadenopathy that was concerning to the clinician for a possible transformation. There was no concurrent lymphocytosis at this point. So he was started on ibrutinib, which is a Bruton tyrosine kinase inhibitor, and he developed fevers kind of soon after that, like within a day or two. So they paused that, and anyway, they were planning to do a lymph node biopsy to see if there's any possible transformation anyway, and that was performed with flow cytometry. So here's the flow. And as we can see, clearly there is a population here of 19 and CD20 co-expressing cells here. And of import here is the CD20 is fairly dim. This population is monotypic, shows monotypic expression of lambda. And again, importantly, the lambda expression is on the dimmer side. This population co-expresses CD5, CD23, and also expresses dim CD22. So this is and is negative for CD10 and CD103. So the very typical phenotype here by flow of a CLL SLL with 5 and 23 co-expression, and even more, if not even more, at least equally critically important is the dim expression of CD20, dim expression of CD22, and the dim expression of surface immunoglobulin, which you almost never see in other small B-cell lymphomas, whether it's mantle, marginal, or follicular. So this combination of the B-cell complex being dim and the immunoglobulins being dim is very, very characteristic of CLL, SLL for the most part. And then, of course, in combination with 5 and 23, this is very characteristic of CLL. Sometimes in CLL, SLL undergoes transformation. There can be immunophenotypic aberrations that can occur, deviations from this characteristic phenotype, or else even at de novo presentation or through different iterations of therapy, CLL can undergo some phenotypic changes, the so-called atypical CLLs, wherein either they may have a little brighter immunoglobulin or may drop their 5 or do only partial 5 or partial 23 and so on. Some of these might be associated with trisomy 12s at presentation and so on. But this particular case appears to have a perfectly characteristic phenotype. So the biopsy was performed, and as we can see in the biopsy, it's a fairly diffuse infiltrate as opposed to the follicles we were seeing in case 1. Here, we don't see any reactive follicles. On the contrary, it's a diffuse infiltrate. There are areas here, as you'll see, of relative pallor, as you can see with my pointer here. So in the sea of this dark purple, there are these relatively paler areas that are kind of ill-defined. They're not really well marked out like a germinal center is, but they look like what would be called as pseudo-proliferation centers, pseudo-germinal centers or proliferation centers, because they are not very well-defined like germinal centers are. At higher power, we see that one of those paler zones here, and the pallor is imparted here because of increased cytoplasm to the cells and, in general, increased size of the cells compared to the small, mature lymphocytes with only scant cytoplasm elsewhere, the dark purple dots versus these larger cells here. And again, yet higher power, this kind of imperceptible sort of spectrum between mature lymphocytes that have these dot-like nuclei and with condensed chromatin. As we go towards the center of the proliferation center, there's a spectrum and increasing size, and then these cells with prominent nucleoli, what would be prolymphocytes in the peripheral blood or paraimmunoblasts in the sections. So a very characteristic SLL small lymphocyte lymphoma morphology with these proliferation centers. And the important thing is we do not see any transformation to a diffuse large B-cell lymphoma, or that's what Richter's transformation. Elsewhere in this lymph node, there are these areas, these really pink areas, and that really looks like necrosis. With necrosis, obviously, one is concerned, maybe there's a potential transformation to a higher grade lymphoma, but we don't see any sheets of large lymphocytes that are adjoining this necrotic area. On the contrary, we see something else. Any thoughts here of what we might be seeing? These structures here? Kind of
please unmute your mic and you can speak straight.
Partially preserved cells with ground glass sort of appearance in the nucleus. The chromatin has been kind of pushed to the periphery. Another cell here and yet another here. Okay, we did an immunostain for this particular inclusion, and we see a lot of brown here in this. Any guesses what this immunostain might be with that changes that we're seeing, the cytopathic changes we're seeing in those cells? All right, this is herpes simplex immunostain, and this is a patient with SLL who are already immunocompromised because of their disease and ongoing therapy, and they're prone to all sorts of infections. And this particular patient had developed herpetic lymphadenitis in the background of a small lymphocytic lymphoma. There was no evidence of a large cell transformation. So the patient was treated with acyclovir. He happened to have HSV that was positive in the blood by PCR. At last follow-up, he was restarted on obinutuzumab and venetoclax, which is a BCL2 inhibitor, and has been stable in the last follow-up. Any questions about this? As you can see with the necrosis, there was not much in the way of neutrophilic infiltrate. For the most part, it was just eosinophilic necrosis with some chelolytic debris. And there was some neutrophils, but not a whole lot. So, yeah. Right. Now, then I'll move on to the next case. Here's case number 3. This is a patient that presented with right axillary lymphadenopathy. He has recently, this is in March this year, he had recently received 2 doses of his COVID vaccines and finished the second dose 2 weeks ago. And lymph node core biopsy was performed. And this is obviously with the, by this time we knew that a lot of patients that had received COVID vaccines, especially I know the Pfizer or the Moderna ones, they were developing lymphadenopathy, and many workups were being done part of that. So anyway, I mean, it might have been spurred because of that, but he did have lymphadenopathy, and this was the coincidental history that he had. So we made touch prep. Now, one thing that we do routinely is when we get needle core biopsies or we get the lymph node biopsies, we make touch imprints of them when they come fresh to us, and all the lymphoma workups come fresh. And it's an important tool because it provides you another cytologic preparation to look at, morphology apart from histology sections. And we also prepare 4 to 6 unstained touch preps, which we can use for additional studies like fluorescence in situ hybridization or FISH for different rearrangements that we might need to use for a lymphoma. So this is the touch prep that was stained with Giemsa, and as you can see, the cells here, the lesional cells here are fairly large here, and they have very irregular nuclear outlines. The chromatin does look mature, so they don't look like blasts or lymphoblasts, or and if this was the nucleus of a normal lymphocyte, these cells are fairly large with irregular nuclear outlines and variably prominent nuclei. There's gingival body macrophages that are interspersed here, indicating again that this particular lesion is fairly active and has a high cell turnover. Here's a section, fairly diffuse infiltrate again, very You can look at the higher power too. Again, when you compare to the normal lymphocytes, these cells are large, and again, high mitotic activity and high tingible body from macrophages because of high apoptosis and mitotic activity. So we know we're dealing with what appears to be a neoplastic process, clearly, and appears to be a neoplastic process that is composed of large diffuse infiltrate of large lymphoid cells that appear to have mature chromatin. So the first order of business is applying CD20 and CD3, right? So I don't have the CD3 stain to show you, but CD20 was brightly positive in all these lesional cells. So when you have large cells and they're all CD20 positive and they're all diffuse, what's our diagnosis here? And thoughts? Everything is already kind of laid out for us, We know it's a lymphoma because it's diffusely facing the lymph node architecture. We know it's a diffuse process, we know it's a B-cell process, and we know it's a large cell process. So it would be compatible with a diffuse large B-cell lymphoma, given all the things that we have objectively shown in this particular biopsy so far, right? Having said that, whenever we're dealing with a B-cell process that is composed of these large cells, and we are dealing with what appears to be a more aggressive lymphoma as opposed to the small mature B-cell lymphomas like SLL, follicular, and modules, and so on, we need to go ahead and dive these further because there are treatment and prognostic implications to better characterize large B-cell lymphomas. So the first order of business is doing some of the stains for trying to type it into AVC or the GC type, germinal center type, or the activated B-cell type of lymphoma. So here's CD10. This particular case was brightly 10 positive. Here is BCL6, which is a nuclear stain, and obviously you can see a lot of the lesional cells here are positive as well. And this case was also positive for MUM1. Now, in the year 2000, we would be familiar when the molecular signature of diffuse large B-cell lymphoma was elucidated. They were divided into two main subtypes. One was the germinal center type, and the other was the activated B-cell or the non-germinal center type. Now, nobody can do gene expression studies in the routine lab, but what we can do is we were looking for surrogates for this in the routine clinical labs to see if we can divide this diffuse large B-cell lymphomas, which is a big group of lymphomas, but that have heterogeneous outcomes into different subtypes and easily by immunohistochemistry. So in 2004, this algorithm was proposed by Hans et al., and it divided lymphomas into large B-cell lymphomas into germinal center or the non-germinal center type, starting off with CD10. So if CD10 is positive, we know that it's a germinal center type of B-cell lymphoma, and that's the end of the story. So, but if the CD10 is negative, then you next to BCL6. If BCL6 is negative, then you know you're dealing with a non-germinal center type of lymphoma. Or if BCL6 is positive, then you do MUM1, and if it is MUM1 positive, BCL6 positive, it's a non-germinal center type. But if it is BCL6 positive, MUM1 negative, it is a germinal center type. So why do we do this? Cell of origin in diffuse large B-cell lymphoma is important, and about these three are the most commonly used and commonly available immunostains in almost every lab. There were other markers that were proposed. There were 3-marker, 4-marker, and 5-marker panels proposed for this to try and subclassify diffuse large B-cell lymphomas. But these three have endured the test of time, have been shown repeatedly in many studies, and been validated to just use these three stains to parse out our large B-cell lymphomas, and we do this routinely in every large B-cell lymphoma. Cutoffs are important. Generally, 30% or more of the lesional cells have to be positive to deem it positive, and these are important for prognosis because in general, germinal center type lymphomas tend to do a lot better than the non-germinal center type, and for identifying groups because many trials are based on whether it's a germinal center type or the ABC type, and that subclassification gets important at the initial diagnosis. So now, going beyond that, we always do FISH studies on any large B-cell lymphoma to look out for MYC rearrangement. Now, MYC rearrangement by FISH, what we perform in our lab is on the touch preps. I mentioned that we do the touch preparations up front. That saves us time while the immunostains are going on the tissue block here. We can send the unstained touch preps for FISH studies at the same time. So in this particular case, our case was positive for MIC rearrangement using the MIC break-apart probe, which just tests that the MIC is rearranged. It doesn't necessarily identify which partner it is rearranged with. It was also positive for BCL2 rearrangement and was negative for BCL6 rearrangement. So we can either order our FISH as a panel where we do all these three at the same time, or we sometimes order it when the index of suspicion is low that the MIC is unlikely to be positive. We'll just go ahead and do the MIC up front, and if the MIC is negative, then we'll stop there and not waste any money on the BCL2 or BCL6 probes. But if the MIC is positive, then we slap on the other two probes. So in this case, we have two rearrangements that were positive. So the diagnosis here is high-grade B-cell lymphoma with MIC and BCL2 rearrangements, the so-called double-hit lymphoma. Instead of diffuse large B-cell lymphoma, we have to call this a high-grade B-cell lymphoma. And that's the thing. Whenever you have a large B-cell lymphoma, you have to do a FISH for MIC rearrangement to further subclassify those lymphomas before you call it a large B-cell, diffuse large B-cell lymphoma. Now, double-hit lymphomas, why identify them? That's important because MIC and BCL2 and or BCL6 rearrangements, that's the defining this thing. They have to, at least two of these have to be present, and triple hit is as bad as double hit if all three can be positive too. That's because it has poorer prognosis, and you have to, if the patient can take it, they have to be treated with more aggressive chemotherapy, like the kind that you would reserve for maybe Burkitt lymphoma or with REPOC, as opposed to a CHOP kind of therapy that you would use for diffuse large B-cell lymphoma. So this looks very complicated, but in a nutshell, it summarizes what I have just spelled out for you so far. This is Mayo Clinic's algorithm for aggressive B-cell lymphoma. And obviously, you start off with the morphology, and if those are your differentials, diffuse large B-cell lymphoma, high-grade B-cell lymphoma, Burkitt lymphoma, those will be your morphologic differentials. They say you start off with FISH, but realistically, you would have started at this end, with the immunohistochemistry. Either way, so when you're done your FISH, if this is positive for FISH, and then positive for FISH for MIC rearrangement and or for 814, so either break-apart probe or the 814 probe, then you do the FISH for BCL2 and BCL6 break-apart probe, and if those are positive, this becomes the double hit like we are seeing in our case. If it is positive for FISH, if it's negative for, let's start here. If it's negative for MIC and it's negative for either the break-apart or the translocation probe, then by morphology, it's a diffuse large B-cell lymphoma, or it's a high-grade B-cell lymphoma if it shows overlapping features with Burkitt. In the DLBCL, which will be the bulk of our cases, which that are negative for MIC, then you do our cell of origin immunohistochemistry with 10 BCL6 and MUM1, as I've stated earlier. And obviously, if it is 10 positive, it becomes a gemellar center type of B-cell lymphoma. If it's 10 negative, as stated earlier, we do BCL6 and then MUM1 to figure out whether it's a non-gemellar type or is the gemellar center type of B-cell diffuse large B-cell lymphoma. And then on this end here, if it is positive for MIC, but then you go ahead and do the FISH for BCL2 and BCL6. And if it is negative for BCL2 and BCL6, then you have to decide whether morphologically is it a large diffuse large B-cell lymphoma with MIC rearrangement, or is it a Burkitt lymphoma or a high-grade lymphoma, B-cell lymphoma, NOS. And if it is a diffuse large B-cell lymphoma, then we go ahead and do the same algorithm for ABC and GC type, or else go ahead and prove that this is a Burkitt lymphoma. And with Burkitt lymphoma, obviously, we know the characteristic phenotype. They're 10 positive, they're BCL2 negative, typical Burkitt lymphomas, and they obviously immunohistochemically will also overexpress MIC. So the big thing is to remember, if we have the ability to do, we should do a MIC rearrangement, because that does have important prognostic and therapeutic connotations. And also do a basic panel of CD10, BCL2, and CD10, BCL6, and MUM1. So apart from this, another two immunostains that you can put put on large B-cell lymphomas are BCL2, which was positive in this case, and the cutoff is that 50% of the cells have to be positive, and immunostain for IHC for MIC, So here the positive cutoff is 40%. So our case expectedly showed both by immunohistochemistry as well. Now this is important, and we do that in cases that are MYC negative. We by rearrangement studies, FISH studies, we'll go ahead and do the BCL2 and BCL6 immunohistochemically to identify so-called double expressors of MYC and BCL2, and that's because there is increasing literature now indicating that these tend to do worse than your regular diffuse large B-cell lymphomas, and might be somewhere in between DLBCLs and your double-hit lymphomas, which are defined by the rearrangement, the FISH rearrangement. So, as expected, this particular patient did have very high serum LDH, as in many high-grade lymphomas. His CBC was normal, didn't have, and then he had pretty prominent hypermetabolic adenopathy, a lot of tumor load. He got dose adjusted because of his age, our EPOC therapy as opposed to CHOP, and they added etoposide. And as of May 27th, his disease seems to be showing a significant response. So we'll have to see how it pans out later. So any questions on workup of aggressive B-cell lymphomas?
Hello, I'm Professor Pranab Bhattacharya of Calcutta School of Tropical Medicine, just retired. And regarding the B-cell lymphoma, there is one variant of the B-cell lymphoma is IgH lymphoma. And what the workup you have to do with the IgH lymphoma? Number one. Number two, did the Moderna COVID vaccine can turn the B cells into a blastic cells, or these are the virusites? There are reports that
Sorry, go ahead.
There are some report that the leukemia developed from the Moderna vaccines, particularly with mRNA vaccines.
I'm not familiar, sir, with the Moderna. I mean, again, I've not specifically looked into it. I do know that lymphadenopathy has been described in these people, and almost always it turns out to be having like some reactive changes and maybe some pericortical necrosis and so on. In fact, the pitfall has been that some lymph node workup that has been done after the onset of lymphadenopathy following the vaccines, there's the risk of like overcalling things as lymphoma, or so I'm not familiar, sir, of transformation or of lymphoma or any causal association with the vaccination, but again, I've not actively looked into it. So I do know in this case it was just a chance association that the patient had a vaccine. He always obviously had the lymphoma. It was just picked up. And then initially, the clinicians thought that maybe it was related to the COVID vaccination, but they were concerned because it looked a little larger than usual, so the biopsy was done. But I can certainly look into it and get back to you, if there's any other stronger associations of lymphoma with the COVID vaccination.
What is about the IgH lymphoma, B-cell lymphoma, a variant of IgH?
Are you talking about the large B-cell lymphoma with IRF4 and or MUM1 reading?
Yes.
Or IgH. I'm not familiar with the IgH large B-cell lymphoma. I know WHO has this IRF4 one or MUM1 large B-cell lymphoma, which is primarily a folliculocentric sort of process.
That has to be differentiated with the follicular hyperplasia, the IgH4.
The IRF4 MUM1 large B-cell lymphomas, yes. So that can be, it's not a very common entity. Yes, the differential here would be maybe reactive follicular hyperplasia or grade 3 follicular lymphomas and so on, but maybe some diffuse areas that are wanting to become like or in transformation to a large B-cell lymphoma. But again, I haven't encountered a case of this particular entity. It's not very common. But yeah, I mean, the WHO book does describe that particular entity. So I don't think that would be a consideration here. We have a very diffuse pattern here of involvement. And anyway, I think the presence of MYC rearrangement here would supersede everything. I mean, MYC and BCL2 rearrangement is what would qualify this lymphoma as a double-hit lymphoma.
Yeah. My third question is that whether the recent treatment of choice for the B-cell lymphoma is ibrutinib or the first generation or the second and third generation of butyrine inhibitors, butyrine kinase inhibitors.
Again, I mean, treatment questions, I would not be in a position to answer because that's really, hemato-oncology is terrain. But I do know that ibrutinib and all, both the Bruton tyrosine kinase inhibitors and ibrutinib are all used as second-line therapies. I don't think they're first-line therapies. For large B-cell lymphomas, it's either CHOP with rituximab, or in these higher-grade processes, it's either EPOC with the addition of etoposide, or sometimes they can do even like hyper-CVADs, like the way they would treat with Burkitt in younger patients. So again, it's really not my area. So, but that's I would refer you to oncology material for that.
Yeah, there is one question there on the YouTube. I'll just put that across to you, which is Hema Chandra is asking this question. Could the necrosis also be part of the treatment? That was regarding the case 2 which you showed.
Because there were viral cytopathogens right in the area next to it, and we know that herpes does incite, a necrotizing lymphadenitis or necrosis wherever herpes occurs, whether it is in the setting of liver or elsewhere. I would think that the necrosis was likely attributable to the herpes itself, because the herpetic inclusions were mostly in the necrotic area only and not elsewhere in the viable node.
Right. Yeah, I think we'll go ahead.
Okay. We next have a case from a 67-year-old gentleman who is a gentleman with known HIV on antiretroviral therapy. He was visiting his family from Kenya, and he presented with fevers and extensive lymphadenopathy that was seen in the chest, abdomen, and the pelvis. So here is a section of one of the lymph nodes that was biopsied, and again you can see somewhat. Let me just see my arrow here. Yeah, some thickening of the capsule here. We can see a little bit. Some of the follicles here. This follicle looks like there is relatively normal germinal center. Elsewhere, the germinal centers kind of look more diminutive. They are kind of a little regressed here. So look at higher power here. Again, some of the more kind of diminutive germinal centers with prominence more of follicular dendritic cells. A lot of prominence of vessels in the interfollicular areas. And here some hyalinization, a little bit of vessels kind of encroaching upon the these atretic or regressed germinal centers. Some suggestion of onion skinning of lymphocytes, kind of trying to bury this atretic germinal center. In the intervening areas elsewhere, we have a lot of plasma cells here. As you can see, make out all of these cells with eccentric placement of the nuclei, plasma cell proliferation. Okay, any ideas what we might be dealing with here? We did do one immunostain with nuclear positivity in a few cells here, as you can see. All right, I'll go ahead and, so this stain is HHV8. Any ideas what this entity is now? So we know we're not dealing with a lymphoma because we know this was not an effaced lymph node, and we had changes here that were kind of overlapping. We had changes that showed regressed germinal centers, some vascular proliferation, and some interfollicular plasma cell prominence. And in this particular case, there's HHV8 positivity in these scattered immunoblasts-like cells. In a person that has multicentric lymph node enlargement and also happens to have HIV. So this is multicentric Castleman's disease. Of course, we have traditionally learned that the Castleman's disease comes in 3 different histologic variants. One is histologic/clinicopathologic variants. One is the hyaline vascular type, the plasma cell type, and the multicentric type. And then there can be types that can show histologic overlap or mixed features between hyaline vascular and plasma cell variants of Castleman's disease. Lately, of course, there's been, and this is a pretty recent paper from 2020, there's been kind of a reclassification of Castleman's disease. And in the lymph node, you start off the classification primarily by the clinical, whether it's a unicentric or one lymph node or one site with two lymph nodes, or involvement, or is it like a multicentric involvement? In the multicentric type, of course, then there's a further subclassification. Is it HHV8 associated multicentric Castleman disease, or is it the IMCD, which is the idiopathic one, or is it POMS associated, which is that same plasma cell dyscrasia subclassification here with polyneuropathy, organomegaly, endocrine disorders, plasma cell dyscrasia, and so on. So that can be one of the associations. Now, as you can see at the bottom here, this is important, that the unicentric Castleman disease is the one that almost always or typically has a hyaline vascular pathology in the lymph node. And if you look at the other end here, the multicentric type, that typically has the plasmacytic or plasma cell morphology, the plasma cell variant, and the mixed variant can be somewhere in between. And in the hyaline vascular type, we'll have the regressed germinal centers, the prominence of the follicular dendritic cells, the vascularity, and the reactive germinal centers that are prominent with plasmacytosis tend to occur more in the plasma cell type morphology, and then there can be a mixed variant. The idiopathic multicentric Castleman disease is further subdivided into a not otherwise specified type, or there's one specific type that is defined by clinical features like reticular fibrosis, thrombocytopenia, ascites, organomegaly, and so on. So that's a clinical phenotype. And of course, there are these diagnostic criteria that are defined now for idiopathic MCD. You need both the histologic changes in the lymph node and enlargement in at least 2 or more lymph node stations. And you need a bunch of 2 of these minor criteria, 11 minor criteria that are present here from clinical and the laboratory side, as you can see. I'll refer you to this publication for all the details. It's not a very common entity, but it's important to recognize also Castleman-like changes that are not fully well developed can be seen in other entities. They can be seen in a lymph node that is otherwise partially involved by a lymphoma, and you can see Castleman-like changes elsewhere in the lymph node. Obviously, workup should include, especially in multicentric cases, workup to exclude other entities. And it's important because the unicentric one, which is typically the hyaline vascular type, is very good prognosis, and you just excise it if possible, or you can watch it. It's the multicentric type, which is really more of a systemic disease, and as was apparent in our case. And frequently, it is a lot of the systemic symptomatology is driven by IL-6, and the treatment that has been the first line of treatment typically is rituximab. IL-6 inhibitors are also used, and there are many other agents that are now many newer agents that are now being employed to treat multicentric Castleman disease. Our particular patient, he went back to Kenya because he was visiting, and rituximab was prescribed for him. But after that, we don't have follow-up as to how he did because of the special circumstances here. So that's all I had in this one particular case. So if there are any questions, I'll be happy to address those. Otherwise, I can move on to the next one.
Dr. Ajay, there is a question and an opinion from the YouTube. I have put that on the chat box, but I'll read it out to you. Dr. Elanthanal Singamanish, he says, these days we are getting more lymph nodes with viral lymphadenitis like feature with or without COVID infection or vaccination. Is it anything to do with the current pandemic, sir?
Again, I mean, as I said, I've not specifically looked into it, but if it is related to, vaccinations or COVID itself doing it, but I would not be surprised if that's happening because, as I said, even in the US, I know that in spite of the fact that knowing that lymphadenopathy can occur within a few weeks of vaccination, we are seeing, some increased biopsies of these things. And then that's something that actually is you have to be cautious about interpreting any lymph node biopsy which occurs in the setting of a viral infection. Obviously, the danger that's been very well documented is with infectious monocytosis. When lymph nodes were biopsied in these, many of them are misdiagnosed as large B-cell lymphomas because of the pericortical necrosis and large immunoblastic proliferation that tends to occur with viral infections. They used to say, in fact, the biggest complication of infectious mononucleosis is a lymph node biopsy because of the potential danger of it being misinterpreted as a lymphoma. So again, I don't know specifically about COVID or the vaccination, but I'll be happy to look into it. I know it seems to be a recurring question.
Please go ahead, sir, please.
Okay. Shall I go ahead? Or?
Yes, please go ahead. Yeah.
Okay. Yeah. All right. So we next have the case 5 here. This is a patient who is undergoing, so we're kind of switching gear a little bit, she's undergoing colonoscopy for regular screening for polyps and so on. So she had small polypoid lesions seen in the cecum and they were resected. So here is an example. So we know instantly that, it doesn't look like a regular tubular adenoma to us. It doesn't look like a hyperplastic polyp, which is probably 90% of the polyps here in the colon. On the contrary, what we see here is an infiltrate. And the cells that stand out are these kind of cells with red granules, like eosinophils. And then there are these other elongate cells here, kind of epithelioid nuclei. They seem to have kind of pale eosinophilic, finely granular cytoplasm. They're kind of percolating, all keeping company with these eosinophils. They're kind of forming a little band, sort of almost underneath the surface epithelium. Okay. Any ideas what we might be dealing with? We did do one immunostain, and that's really highlighting these cells. Spindle cells with paleoeosinophilic cytoplasm, hematopoietic origin. They kind of discohesive. All right. This is CD117. And giving them company were eosinophils. So with that histology and with this immunostain and company with eosinophils, these appear to be spindle mast cells. Spindle cells, when mast cells normally should be epithelioid and kind of look more kind of rounded or like this. When they're spindled, and like we saw, that's an aberrancy, and that's we know that that's a big tip off for us to see that they're atypical mast cells. And another way to, in the lab, fairly easily demonstrate that they're atypical is either show co-expression of CD2 or CD25 in these mast cells. And this is CD25. You can see the same cells are marking with mast cells where CD25. Mast cell tryptase, which is a very specific stain but not as sensitive, appears to be negative in these lesional cells. It's marking the what appear to be normal mast cells in this particular biopsy. All right. So given this, we were a little surprised because I hadn't seen this in a GI biopsy primarily before. So it was a first for me. So we call this atypical mast cell infiltrate and recommended evaluation for systemic mastocytosis because both the spindle cell nature and the confluent nature of those mast cells was abnormal, as was the CD25 co-expression. So I looked up at that time. There is this seemed to be the largest study of evaluating GI involvement by mastocytosis. So from 2014, and they studied 70 biopsies from 24 patients with GI involvement. Also compared with mast cells that could be seen normally in just asymptomatic patients or patients with irritable bowel syndrome that had more diarrhea-like features. In 16 of these 24 cases of systemic mastocytosis, the diagnosis was first made on the GI biopsy. 17 patients had cutaneous mastocytosis. 15 of these 17 patients also showed bone marrow involvement. Colon was the most common site of involvement, followed by ileum, duodenum, and then stomach. And then again, there was a GI symptomatology related to this. As mentioned, oval to spindle mast cells and aggregates frequently in subepithelial bands, frequently co-expressing 25 and 117. And about a quarter of the biopsies only had single aggregates. Again, eosinophils are a prominent feature in biopsies from the ileum and the colon. As opposed to the systemic mastocytosis cases, the normal patient or the IBS patients only had singly dispersed mast cells. And between these two groups, there was an overlap. So there was some, there's no way you could, tell if the number of mast cells was more in IBS versus normal. So anyway, so this was, the key thing was that this thing was well documented as potentially initial presentation. Well, 2 months later, the patient did present with a skin rash, and the biopsy showed cutaneous mastocytosis. Her CBC was normal, her serum tryptase was normal, and 4 months later, when she underwent bone marrow biopsy, that demonstrated 3 minor criteria that fulfilled the threshold for systemic mastocytosis. She had interstitially scattered spindle mast cells that were more than 25% of the overall mast cell infiltrate that co-expressed CD25, and her mutation, the c-KIT mutation, was positive in the bone marrow aspirate. So this was GI involvement by systemic mastocytosis. Any questions on this case?
There are actually on the YouTube, people are parallelly diagnosing your cases.
You
can see that,
and I can't see YouTube simultaneously.
No, it doesn't matter. You just go to the chat box section of Google Meet. You can see I have put all the questions there and the comments, so you'll be able to. Doesn't matter. Just go ahead. You just go to the presentation. You can see that later.
Okay.
If there are no questions,
good.
we can go ahead. Make it full screen and we'll start.
Okay. All right. Then. Okay.
Yeah. Thanks.
All right. So here's case 6. This is a 52-year-old gentleman who presented with, who has a history of renal transplant in the 1990s and is on the regular immunosuppressants. He presented with neurologic features of aphasia, right-sided weakness, and facial droop. His MRI showed changes that were, described as multifocal geographic areas of heterogeneous hyperintensity in both cerebral hemispheres, and imaging-wise, if either favored progressive multifocal leukoencephalopathy, infectious diseases were in the consideration as well. So they did some CSF, which just showed some lymphocytic pleocytosis, no evidence of tonal B cell population by flow. CSF was positive for Epstein-Barr virus by PCR, and they did obtain a brain biopsy. So here is brain tissue. Clearly, we see that the action here is in the meninges, right? The brain parenchyma is for the most part spared. Here's another kind of, involvement here, primarily limited to the meninges. And we look at some of this infiltrate at higher magnification, and we see that the vessels here are fairly obscured here, by this fairly robust infiltrate. Very angiocentric, almost angioinvasive sort of infiltrate here. Again, very heterogeneous infiltrate, small mature lymphocytes, there's some histiocytes that mixed here. In the midst of all that, there's larger atypical lymphoid cells here, even a mitotic figure here, than these larger cells. Kind of again, showing the fairly angiocentric nature of this infiltrate, primarily limited to the meningeal vessels here. Again, large cells. So we did the immunostains. This looked like an atypical infiltrate, obviously, and hematopoietic infiltrate. So we slapped on some stains. So here is CD20. So CD20 appears to be highlighting a lot of these larger atypical cells here that we saw on H&E. Here is CD3. So by contrast, it's hitting more of the smaller cells, and you can see the larger cells here are negative. Again, kind of higher power, the larger atypical cells are negative. It's the smaller cells that CD3 is hitting. And then we went ahead and did in situ hybridization for Epstein-Barr viral encoded RNA. And clearly, we see that that's positive in a lot of these larger cells that were around these angiocentric, around these vessels in this angiocentric infiltrate. Any thoughts as to what this diagnosis might be? We know the setting here is a post-transplant setting. But just by morphology, or for example, let's just place this, if this was in the lung and you had an angiocentric infiltrate that was composed of large atypical B cells that were EBV positive and were set in a heterogeneous infiltrate of mature lymphocytes and histocytes, what might you consider?
Just give us a minute, because the YouTube people take about a minute to respond.
Sure.
Yeah, Dr. Indrani Karmakar says PTLD.
Yes, absolutely. We know that the setting here is perfect for PTLD, and we know that many of these are driven by EBV. And it is a
Dr. Nilesh Kapadia says large B cell lymph node of intravascular type.
So for intravascular, the thrust of the infiltrate should be within the lumen of the vessels, and they are pretty disseminated processes. Here, a lot of the infiltrate is around the vessel and into the vessel wall, as opposed to being luminal. So, and again, it should be...
Sigamani says lymphomatoid granulomatosis.
Right. That, I think, is the diagnosis that totally fits the bill here, because you have an angiocentric infiltrate, as I said, of these large atypical lymphoid cells that are not confluent, but are set in a background of mixed infiltrate of lymphocytes and T cell lymphocytes and small lymphocytes and histocytes and so on. And this, in the lung, you would call this lymphomatoid granulomatosis. And in this particular setting, it is post-transplant lymphoproliferative disorder of it's meningeal lymphomatoid granulomatosis. So kind of this PTLD is of this particular type, because this is kind of clearly not a very usual involvement here. This meningeal involvement alone is very uncommon in lymphomatoid granulomatosis. Of course, lymphomatoid granulomatosis has been described everywhere in the body, apart from the lung, including in the CNS, but the meningeal involvement alone is unusual. This particular patient did have very good response to rituximab and to kind of dose adjustment of his immunosuppressive therapy. And obviously, you need to ensure that you've ruled out other infectious processes or other lymphomas that were being considered before reaching the diagnosis in this particular setting. So that was a PTLD of a specific type. And if there are any questions, I can take those, or I can move on to the next case. I know we are running kind of already an hour down.
Please go ahead.
Okay, so I have 3 more cases, and here is case number 7. This is a person who presented with adrenal insufficiency and hypothyroidism, and the brain showed a cellular mass, and this is an 80-year-old woman. So here is an infiltrate, a section from the mass. So we see kind of purple and these pink areas. Purple areas of what appear to be a hematopoietic infiltrate, and these pink fibrotic areas, storiform fibrotic areas that are running through. And the infiltrate itself appears to be pretty rich in what these are all plasma cells. We've seen a lot of plasma cells today. And the lymphocytes, the smaller, darker lymphocytes. Small mature lymphocytes, plasma cells, and storiform fibrosis. Again, higher power. Again, we can see a lot of those plasma cells, lymphocytes. When we did the kappa lambda on the plasma cells, we know that these appear to be benign, polytypic expression, kappa and lambda. So if you have a lymphoplasmacytic infiltrate of polytypic plasma cells set in a storiform fibrosis, that should be a tip-off for doing some additional work up here. And that's what we did here, and I'll go ahead and show this. And this is IgG4 here. And IgG here would pick up all the plasma cells. You can also use CD138 as a surrogate for this. And here we have IgG4. And what we see here is that IgG4 is a substantial subset of all the plasma cells here. And if you were to do per high power field count, it would definitely, I don't have a count right now offhand, will definitely be more than 40 or something per high power field. And as a proportion, I mean, it seems to be a fairly high proportion, about maybe 60-70% at least of these overall plasma cells are IgG4 type. So what you have here is and IgG4-related hypophysitis. IgG4-related disease has been recognized in the last 20 years, obviously, and we are seeing more and more literature pertaining to this. We have recognized IgG4-related disease as different fibroinflammatory processes all over the body with different names. Of course, pancreas was the first site where IgG4-related disease was first recognized, and we now we also call it type 1 autoimmune pancreatitis. And many of these cases, unfortunately, at that time were identified on Whipple's specimens because they all mimicked a pancreatic tumor, and frequently, they were never diagnosed as malignant in any pre-op biopsies, but that is the case with so many pancreatic biopsies anyway that they can be turned out to be benign or may not be representative enough. So patients did undergo dissections, and at that time this particular entity was recognized as a tumor factor lesion, fibroinflammatory lesion that is otherwise benign and could potentially respond to steroids without the need for surgery, and therefore the importance to recognize this entity. Obviously, it's also important to recognize this as a systemic sort of syndrome which can affect multiple organ systems, either concurrently or sequentially in a patient. In the orbit, we recognize this as inflammatory pseudotumor. Similarly, in the lungs as well, salivary glands, lacrimal glands are other frequent sites of involvement. In the lymph node, the fibrosis part can be far less conspicuous, and you have more what is called IgG4 lymphadenopathy. Hypophysitis, as in our current case, is another well-known or well-documented presentation. And in the retroperitoneum, we recognize many of these cases of idiopathic retroperitoneal fibrosis are actually turned out to be IgG4-related disease. Similarly, for fibrosing mediastinitis and so on. So this particular article from 2017 is a good review. You can refer to this for more details as well. But the first basic way to identify this is histology. If there is no histology that is suggestive, then you don't invoke this diagnosis. The problem is that nowadays a lot of the clinicians here say, hey, test for IgG4 or whatever, and there's no point just doing the IgG4 stain, slapping that on whenever you see a plasma cell. You have to have the characteristic histology to begin with, and that is that you have to have a dense lymphoplasmacytic infiltrate set in a fibrotic background, and typically it's a storiform fibrosis. You can also see obliterative phlebitis, but that's less sensitive as a histologic feature to be present. Eosinophils are frequently admixed, perineural infiltrate is frequent, and generally you do not see granulomas, you do not see necrosis, you do not see neutrophils. And so if you see those, that should take you away from IgG4-related disease. So when you have this sort of histology to begin with, you slap on IgG4 and IgG stains, or IgG4 or CD138 maybe, in lieu of IgG, and then look for IgG4 cells per Hapar field, and I'll refer to a table in the next slide where the number of IgG4 cells per Hapar field varies in different organ systems. But another important thing is ratio is important. The IgG4 to CD138 or IgG ratio is over 140, over 40%. There is role of IgG4 levels in the serum. Cutoff of greater than 135 milligram per deciliter is touted to be pretty good, and at least has a very good negative predictive value. The key thing, though, is careful clinical and imaging correlation to make sure that that fits with your diagnosis. This one of the first statements that came out for consensus diagnosis on pathology side for this disease was by Dr. Deshpande et al. In 2012, and this table is from this paper which talks about the number of IgG cells per Hapar field. The requirement is a lot lesser in certain sites. For example, only 10 apparently suffice in meninges and so on, to higher requirement in lacrimal glands and salivary glands and so on. And then, of course, you start off with histologic features as the big thing. It's important to contextualize it. IgG4 cells can be raised in other immune disorders like rheumatoid arthritis, multicentric Castleman disease. Stage of the disease is important because in later stages when fibrosis will predominate, especially in biopsies from the retroperitoneum, obviously, which will be needle core biopsies and not excisional biopsies. Any prior steroid therapy can decrease the number of plasma cells. So caveats are important to when you are analyzing biopsies, but an index of suspicion should arise if you see the histology that's suggestive of this entity. Again, clinical mimic of malignancy and therefore the need to identify it, and histologically you have to rule out lymphoma, especially marginal zone lymphomas that can have extensive plasmacytic differentiation. And it's important to recognize this because generally there is a very good response to steroids or rituximab for this entity. So that's all I have for IgG4 related disease. And again, I would refer you to both those papers that I listed in the in the preceding slides as very good reviews. I can move on to the next case if there are no questions.
There is one question by Dr. Sigamani. He says, can we get light chain restriction in IgG4 disease?
No, you should not, because then you're dealing with a lymphoma, with a plasmacytic differentiation. I would take Ig because there should be polytypic cells here,
Right, sir. Please go ahead.
Okay. We have the second to last case in a 19-year-old male here who presented with lymph node enlargement in the neck. He had mild fatigue, no other symptomatology. This had been going around for a few months, and he eventually thought he'll seek care for this. So this was biopsied. So here is the lymph node here. Again, we see partial preservation of the node structure. We see these reactive geminal centers, but there is a lot of pink business here, outside of the geminal centers in the paracortical zones. Again, a geminal center, but kind of more eosinophilic sort of areas here. At higher power, there's a lot of necrosis. And what else we see? We see a lot of these nuclear debris or cheirorectic debris here. At higher power, again, extensive cheirorectic debris. But what is conspicuous by its absence are neutrophils. We don't see many neutrophils here. And we see a mix of cells here. We see lymphocytes, we see some immunoblasts, and then there are these cells with kind of crescentic shaped nuclei, like here, that appear to be histocytes. So, all right, so when you're dealing with this, what you have here is a lymphadenitis that has necrosis. And your differential diagnosis, of course, is pretty wide, from infectious to neoplastic entities to specific inflammatory entities and so on. And in India, of course, we see a lot of tuberculosis and then necrosis, necrotizing lymphadenitis in general, you may worry about it, but almost always when you have necrosis, it's in the setting of necrotizing granuloma. And what was absent in this particular lymph node was any granuloma. So that would be very unlikely to be mycobacterial or fungal infection with that pattern. Certainly viral infections can do that, so it can certainly be infectious in that setup. When you think about necrotizing lymphadenitis, you may worry about more specific infectious etiologies like cat scratch disease, but then they tend to have more suppurative granulomas, and you have neutrophils frequently in the center associated with the necrosis, and do have a palisade of histocytes and so on. Clearly, when you see necrosis, you'll be concerned about lymphomas, especially high-grade lymphomas. And in this particular case, we did not see any diffuse infiltrate of atypical lymphoid cells. So that would be unlikely here. Of course, idiopathic is the wastebasket when you don't have a cause, obviously. But more specific entities that you can see necrotizing lymphadenitis in are what is going on in this particular case. What is conspicuous here is the lack of neutrophils. So any thoughts on the diagnosis? We did not see any viral cytopathic changes. If not, I'll move on.
There are a lot of thoughts there. I'll just post it here and I'll read it out to you one by one.
Yeah, sorry, there's a delay for me. Yeah.
Just give me a minute, please. Yeah. Dr. Indrani Karmakar says Kikuji's disease Dr. Emmanuel Paul says Kikuchi's lymphadenitis. Dr. Singamani says Kikuchi's. Dr. Nilesh says Kikuchi's. Dr. Badrinath says Kikuchi's. Hemachandra says rule out SLE. Dr. Singamani says also we need to rule out connective tissue disorder like SLE.
Perfect. Everybody's on the mark here. This is a very classic case, as I said. By histology, we call it histocytic necrotizing lymphadenitis, and it is completely consistent with Kikuchi's disease, and it's important to rule out lupus lymphadenitis because they can be identical. In this particular case, the patient did not have any evidence of lupus, and his lymphadenopathy, as expected, resolved when he came for his 1-year follow-up visit. So, a very classic case of Kikuchi's disease, and they do keep coming, like probably see about two a year or 3 a year, sort of. Not uncommon. I mean, uncommon, but still not very rare. And those histocytic, those cells with crescentic nuclei in the plasmacytoid and very slow proliferation that you see, you typically don't need any beta stains for this. The big thing is to exclude any other lymphomas or any other specific viral or other infectious sort of etiologies. So that's all I have for this particular case. I can then move on to the last case of the day.
Yes, please. Thank you.
All right. Well, the next case is a 56-year-old who presented with inguinal adenopathy, and she underwent this lymph node excision. And again, as we can see, here are some follicles here that are preserved. But the rest of the architecture, there's a lot of this interfollicular expansion here with this infiltrate here. Kind of, you see the pink areas and a few preserved follicle and some normal pericortex, but this business is all abnormal. We see a fairly monomorphic population of these largish cells here that have nucleolus, some degree of cytoplasm. There's some mixed cells here. You can make out like these guys with eosinophils, very brick red granules here, right? All right. So we did some stains. Here is CD20. So that seems to be marking the germinal centers here in the normal reactive follicles. Our infiltrate is negative. Here is CD3. It's again, the infiltrate itself is negative. It's mostly residual small T cells here. So any ideas? Not a B cell process, not a T cell process. What now? Any other stains that we can do? That does look hematolymphoid because they're loosely cohesive cells or mostly discohesive cells. So certainly you can have other malignancies involving a node. Could be metastatic melanoma, could be metastatic carcinoma, not really, but yeah, but it's an undifferentiated appearing neoplasm. So if you were to do an Oscar cytokeratin or S100 for melanoma or Saxton for melanoma, that would certainly be plausible. And if you want to do that, I can say that they were negative. So, all right. We did this one stain, and as you can see clearly, it is hitting all the cells here that are lesional cells here, and it's sparing the regular lymph node is negative, and this is lysozyme. So we are dealing with clearly a monocytic process here, myelomonocytic process. Here is myeloperoxidase.
That is what the comment was from Dr. Indrani Karmakar, MPO.
Yes, and then absolutely on the mark. MPO is positive here. Here is CD34, obviously very bright in the capillaries, but also hitting in a subset of this infiltrate in a relatively dimmer fashion. So this is a case of a granulocytic sarcoma. An important histologic clue when you have mostly undifferentiated cells is the presence of eosinophils and eosinophilic precursors. When you see that it mixed in what appears to be an undifferentiated malignancy, that can be a tip-off to, test for this particular entity. Otherwise, you'll do 45, maybe it's positive, negative for BNT markers, and you're, kind of potentially stuck. But eosinophils would be a good tip-off. They're not always there, but if they're there, think of the entity. This particular patient presented with this, but and when they did the rest of the workup after the lymph node biopsy was read, she had a bicytopenia on her CBC. Her bone marrow did not show frank AML, but it showed a myelomonocytic disorder, CMML, and MDS, MPN overlap syndrome. It's a chronic that met the criteria for chronic myelomonocytic leukemia, with 7% bone marrow blasts, 3% circulating blasts, and megakaryocytic dysplasia. Her karyotype was normal at that time. She went all the way to a bone marrow transplant and was in remission, but unfortunately she developed a lung adenocarcinoma 2 years after the bone marrow transplant and died of the lung carcinoma itself later. So granulocytic sarcoma, just want something to keep in mind. Can present in the nodes as well, or obviously can present anywhere else outside of the marrow. So that was my last case. And I thank you for this opportunity, and I can take a few questions if there are any.
Right. Let's wait for the questions. If anybody wants to ask any question from the Google Meet, please unmute and ask.
Is granulocytic sarcoma are found also in the myelomonocytic variant or just the M2 variant AML?
You can have any kind of myeloid leukemia presenting as a soft tissue extramedullary mass. Frequently, myeloid leukemias that show monocytic differentiation are propensity, higher chances of forming granulocytic sarcomas, whether it is in the gums or clearly in the spleen and the liver, and or in the soft tissues and so on. So not infrequently they will show monocytic differentiation. Lysozyme, CD68 are both great markers for this, and lysozyme I've used very frequently because it's a very sensitive and fairly specific marker in this context. MPO, if it is positive, is very, very helpful. But MPO, as you would know, even in the bone marrow by flow and so on, it's relatively less sensitive. And of course, CD34 again would demonstrate immaturity to the cells, but may not always be positive.
Any other question? No, there are none. There was one question which was typed by Professor Pranab Bhattacharya. He said, what should be the level of IgG4 in the blood and what should be the treatment of this disease?
Yeah, so IgG4 level that I would refer you to that 2017 paper that was included. They say that levels above 135 milligram per deciliter are frequently encountered in IgG4 disease. But again, there are caveats that IgG4 levels can be high in many other inflammatory disorders as well, including rheumatoid arthritis, for example, and so on. But typically, if it is at that particular cutoff, they said that it is a fairly high negative predictive value of 96%. But again, it has to be contextualized, and as far as treatment goes, yes, rituximab is the and steroids are both used as first line of treatment for IgG4. That's all I have. Any other questions, or?
Yeah, there are no more questions. Dr. Ajay, a wonderful presentation. Thank you so much for consenting to come on this platform and sharing your cases and knowledge with us. Wonderfully done. Excellent. Dr. Ravindra Kumar Saran. Very informative session. Thanks, Ajay. Enjoyed thoroughly. very useful for practical diagnostic use. That's
Thank you so
Dr.
much for the
Saran
opportunity.
from Delhi. Right. Right. Thank you so much, Dr. Ajay. Thank you so much. I think that's all for the day. Bye-bye. Take care.
Thank you. Bye-bye, everybody.
Thank you. Bye. Bye.